slides? Yeah, great. Hi, Violet.
I just didn't hear your reply. I thought you.
I just saw your message now.
Right, I'm going to make a start if that's okay, everybody. Hopefully a few people join, but Sarah from the network is kindly recording it, so it will be available for others. What I thought I'd do today is, obviously a month ago, two of my team delivered an overview of delirium. What I thought I'd do is just recap on some of the key themes from that presentation and then answer any questions if there are any questions, but hopefully get some feedback from the guys in the room about what they're doing in their units and any kind of barriers or any enablers really. So I've got a small slide deck, about 20 minutes worth. I'll run through that if that's okay. And then hopefully we can have a little bit of a discussion. So sorry, you've got to listen to me for a little bit. I apologise. Just everybody seeing the slides? Yeah, cool. All right. Okay. So like I said, very informal. We'll just go a little bit over a bit of an overview about what you've learned so far, but add a few bits and bobs in that weren't in the first presentation, just to kind of give you a bit more tools in your armory, really. So kind of delirium, like all of you on the call, has frustrated the hell out of me for the last 15 years in ICU. Obviously, it's a massive problem and the literature really isn't there to support kind of guidance and treatment. And if you look through history and historic events, it's always in the literature as part of kind of human illness. It's been reported kind of in the Roman times up to now. So it's something that we might never eradicate, but it is something that we need to do better research on, and hopefully that will come in the next decade. So let's talk about what we do know and what we can do in our gift as a occupational therapist. All right. I'll point out this article. It's getting old now, it's 2018, but it's a really nice overview of pathophysiology of delirium. So if you have time, have a little read of this one. It's a really nice, good one. But kind of it breaks delirium down into kind of 5 subsections. It looks at kind of emotional dysregulation. So these patients are irritable. Sometimes anger comes out. Lots of patients are fearful with kind of paranoia and anxiety. And some people are perplexed. They just don't understand kind of why you're kind of talking about certain situations. Circadian rhythm is a huge one. This disturbance of sleep-wake cycle. We have small receptor sites in our eyes that kind of are inbuilt day-night regulators, really. And there's research out there now with blind people saying that they can tell when the light's on and when the light's off. So they are there. If people are kind of isolated in dark rooms, we are doing them a disservice. So that's kind of where the evidence comes about with kind of day night, trying to get people outside, looking at Lumi lights and such. Impairment of consciousness and attention, so reduced ability to direct, focus, sustain, and shift attention. I think that's the main kind of quote we all kind of deliver when we talk about classification of delirium. But we also have disturbance of cognition as well. So patients' ability to kind of look at the perceptual disorders impaired, of abstract thinking and comprehension, memory impairment and disorientation. And then within this paper, they talk about kind of delirium phenotypes, and they kind of classify 5 phenotypes. So we're all aware of our 3 classifications, our hyper, hypo, and our mixed. But then there's kind of catatonic, and then there's kind of hyperexcited as well. These are actually rare, obviously, but they do exist. So like I said, if you're interested in delirium, this is a top recommendation for me to have a little read of this paper. In the paper as well, it talks about triggers of precipitating factors, and these are all things that common sense kind of tells you really or informs you. So acute illness related to the factors around that individual. medication related factors, and then environmental factors. I think we're all aware of those. This slide came up in the first session, and this is a really nice kind of benchmark about how to start to classify, screen your patients, I suppose, and kind of what is in your gift of change for those patients. If you look at the non-modifiable side of things, as an occupational therapist, really, we're not going to be able to affect any of those, really. It's the modifiable kind of section that we do have an influence and should be part of our risk assessment. I'm not going to dwell too long on this one because it comes up in our further slides. So if we go back to kind of the pathophysiology of delirium, it's really unclear still. There's lots of hypotheses out there about kind of neuroinflammation, the release of stress hormones or a stress response, imbalance of neurotransmitters, and a kind of altered delivery in our neural networks. They've all been considered, and just a bit of a, I suppose, I can't think of the word now, but I think kind of thinking about my experience of working with patients with delirium, it's multifactorial and it's all of these things, but let's kind of unpick them a little bit further. So if we think about kind of structures of neurotransmitters, this is a huge one that we should be aware of, really. So kind of evidence tells us with patients with delirium, we have a reduction in serotonin, a reduction in GABA, and a reduction in acetylcholine, sorry. So if you think about kind of what those neurotransmitters do, so serotonin affects our mood, GABA affects our calming influence, and acetylcholine is our learning transmitter. So all of these transmitters are blocked. And a really nice analogy is like you're going to a nightclub and you've got the bouncer at the door. GABA, acetylcholine, and serotonin, their names aren't on the list, so they're not coming into the nightclub. Okay, but dopamine's paid extra. They're on the VIP list, so they're on the list, and they've got all their mates on the list as well. So with patients that are critically ill, you have a surge of dopamine. Okay, in moderate amounts of dopamine, it's a pleasure neurotransmitter, so it's really nice. But when you've got too much of it, it can cause havoc. And what can happen is patients have altered sensation of their environment. This is kind of the neurotransmitter that causes dysregulation, causes hallucinations, and lays down those really kind of traumatic memories later on for patients when they are coming back to follow-up clinic. So that's just something to consider. I never liked bounces. The other one is cortisone. So kind of cortisone is steroid hormone. So obviously our patients are critically ill. So they have a metabolic dysregulation. So they have a huge imbalance of their metabolic system. Our body kind of detects that and it sends out a hormone stress response. And obviously the stress response is cortisone. If you've got too much cortisone in your system, it can increase your heart rate, increases your blood pressure, increases your blood sugar level as well, and it can impact your memory and your mood. The other kind of hypothesis in the mixing pot is oxidation impairment. So if you think about oxygen, so we use oxygen to break down carbohydrate. So if you think about kind of school and science, you got that ADP and ATP. So you're breaking down that bond to make energy. The brain uses about 20% of our oxygen need. So whatever we take in, 20% of it is directed to the brain. And neurons use 75% of that 20%. So your brain is very oxygen hungry. If we have a decrease in oxygen supply to the brain, this can cause an inadequate oxidative metabolism. This can lead to damage, and your cerebral dysfunction is impaired as well. It can cause altered neurotransmitter level kind of function. So you've got more bounces kind of preventing neurotransmitters to cross the synapse, and then you've got a huge impairment. And this can kind of result in trauma, severe illness, frank hypoxia, intrinsic lung disease, and cardiac disease as well. Frank hypoxia is a big one in the literature. So if you have somebody kind of who's admitted with that, think about kind of hypoxic results. The other section is thinking about inflammation markers as well. So your CRP, your C-reactive protein. When you've got an inflammation, I always think about heat and an imbalance in your equilibrium. And you think about kind of your barriers of your cells as well. Your cell kind of membrane isn't working as effectively as it should be. So things aren't leaving the cells as they should do. Things aren't going into the cells as they should do. So you get a big build-up of toxins in cell levels. And then that kind of reduces your efficiency of your cells. There's also a disturbance in your blood-brain barrier as well. And a really nice kind of analogy where I always remember it is like thinking about Star Wars. You've got Luke Skywalker. He's got a lovely helmet when he's in his starship, okay, protects his head. But kind of when you've got a critical illness, you're changing kind of that starfighter helmet to a colander. So the colander's got lots of holes in it, lots of toxins, lots of bacterium can go into your brain, which shouldn't be there. And then you get this sense of free radicals as well. And this is kind of abundant when you've got somebody with sepsis. And you can see with the bar chart there, this is a really nice paper back in 2018 as well. Looked at kind of two cohorts, patients with sepsis and patients without sepsis. The guys with sepsis are about 50% chance of getting delirium. The guys with no kind of sepsis, it must be about, I don't know, less than 20% there. So it's a huge factor to consider. Now, we touched on this last month about metabolic drivers. So this might be infections. It might be kind of your ability to get rid of infections from your kidneys or your liver, sorry. And we classify that with our CRP, our white cell count, our urea and electrolytes, and how our kidneys are filtering. So kind of looking at your EGFR, and your EGFR is a mathematical equation. And it really tells us about your kidney function. I expect you've all come across this little protractor picture here. So if you've got somebody with an EGFR of 0 to 15, they are in chronic kidney failure. These are guys that are going to dialysis units 3 times a week. In the light orange there is kidney disease. So again, they might have some hemofiltration, but normally it's diet or medication related or controlled. And then 60 to 90, you've got your early stage kidney disease. So they're beginning to access services. And then 90 to 120 is normal. And then the last one in our kind of line there is liver function tests as well. So how is your liver performing? Your liver's got, I think, over 200 functions within your body. And one of the main ones is waste disposal. Experts are trying to get rid of toxins into your system, or out of your system, sorry. So let's explore that a little bit further. So Violet, kind of at the last one, I talked about kind of using an A to I. So this is what we do in Bristol. You'll be aware of the majority of them, but we've just added a few more. So F, G, H, and I. And what you can do when you're kind of clerking your patients and building your risk assessment, you can put some of the biochemistry into your A to I, just so you can track changes, and it also influences your risk assessment as well. So kind of for an example here, so obviously airway, you put your kind of tracheostomy or your endotracheal tube or own. Breathing, same as kind of what you guys do. So you're looking at your FiO2, your respiratory rate, your SpO2, your mode of ventilation. So that might be high flow or optiflow. It might be a ventilator, so CPAP or SIMV or APRV, whatever. And some people put tidal volumes in there as well. I tend to put in there kind of my blood gases as well, so pH, looking at kind of PCO2 and HCO3, just to see if it is a respiratory or metabolic driven problem. And again, I only do that really just to inform my risk assessment. It's up to you if you utilize that or not. Circulation normally is about kind of your heart rate and your blood pressure. No changes there. And then in disability, you can put certain drugs that kind of might have an effect. But I also put in there my GCS, my RAS, and my CAM-ICU score as well. Exposure normally is about kind of your lines and what's attached to the individual. And then in fluids, I start to kind of unpick my biochemistry. So in there, I will put in my creatinine, I'll put in my urea, I might put an AKI score as an overview. If it's terrible, I might put an EGFR in there as well. And then I might put my electrolytes in. So if there's apparent kind of issues, maybe like with my phosphate, I might pop that one in there as well. Or sodium. Those are normally the ones that really affect cognition and confusion. And then in my gastro side of things, I start to unpick my kind of hormones related to my liver function test. That's my ALK phosphate, AST, and the ALT as well, just to see kind of what are the metabolic drivers. In my H, I put my hemoglobin. So obviously it's really imperative to understand what your HB is, because if you haven't got enough taxis delivering things to cells, then your cells are at a huge risk of imbalance and not working as effectively as they should be. And also, again, if it's kind of under 70, they need a transfusion. So again, you're not going to be doing anything out of bed really if you've got a really low HB. It's not going to be pleasant for the patient or you when you've got to pick them up. If you think about I as well, your infection markers, so that's your kind of CRP. And I tend to look at the trend as well. Is it going up or is it going down? And going back to heme, I often put kind of albumin in there as well, just to look at kind of edema management, but that's a different talk. So if we just look at the slide here, so this is somebody's real numbers. Obviously, they're in a bit of a pickle, aren't they? So they've got an active infection. So they've got an inflammation marker here of 142. Everybody on the course should have a CRP of 0 to 5, really. So this person's pretty high. Obviously, we see it higher, but they've got an active infection there. If we look at their kidney function or their metabolic waste disposal team, they haven't got AKI, but they have got kind of creatinine, which is very high, and a high urea as well. So that might affect somebody's cognition or delirium. If we look at their basic electrolytes, not bad, or within the kind of functional status. EGFR isn't crazy. So that's a good outcome, hopefully. So they have a good kind of kidney function. But if we look down here, if we look at phosphate, they might have an imbalance there, just to think about. And then obviously liver function, huge kind of factors there just to kind of play in about kind of waste disposal as well. A little bit low with their albumin, so they might be a bit puffy. They might have fluid in the wrong spaces. So it's just something to consider. Any questions on that slide? I've just talked a lot. Any new concepts? Anything that you already knew? Everybody happy with the structure? Yep. Thumbs up from Violet. Yep. All happy from Josie. Beautiful. All right, cool.
It's a lot, isn't it, James?
Yeah. Yeah.
That's my first thing of looking at that. I'm like, oh, I've not got all of that at the minute.
Okay, but you know, this is the whole point of doing this, right? Yeah.
Yeah.
So kind of my challenge to you is start to play around with the A to I.
Yeah.
And start putting your numbers in. And what I do kind of with my juniors is kind of I put all the numbers down, then I get them to ring the numbers which are kind of not within the range. and then you use all those little numbers that are ringed to think about your risk assessment.
Yeah, I think that's what I might do myself. I mean, it's
Great.
only me, isn't it, here? So, but yeah, I think I might start doing that.
Yeah.
It's a good starting point.
Yeah,
Thank you.
perfect. Absolute pleasure. And, you know, this is kind of what we want to do. We want to make sure that we're all delivering high quality assessment, right? And screening. Perfect. Thank you. So you've got your mixing pot. You've got somebody who's deranged in lots of kind of biochemistry. You've scored them, or you're about to score them or screen them. How do you do it? So you've got two tools really. There isn't much that we can utilize really, but there are two. There's the ICDSC, which is a screening test, and you've got the CAM-ICU, which is a diagnostic test. So let's explore those. So the ICDSC is the intensive care delirium screening checklist. So like I said on the previous slide, it's a screening tool really. So you can use this to screen your cohort if you wanted to, and it's quick. It's quite easy, especially if you're on a computer, and you can start to unpick from narratives from your notes to see if somebody's delirious or not, or at high risk of being screened as delirious. Is anybody using this just out of interest? No? It's used a lot in Australia and America. A team up in Leeds has moved away from CAM-ICU and started to use this, and their rates of screening CAM-ICU has gone up quite considerably. So that's just something to think about if your unit, like ours, is struggling just to do a basic CAM-ICU. Might be something that you can start to utilize. So there's that one. And then obviously we've got the CAM-ICU, which is more utilized. The problem with CAM-ICU is it can be a bit subjective. You get lots of nurses and therapists and doctors that do endobedogram. So they just say, oh, they're positive or they're negative without going through the stages, which is a bit of an error. And lots of people feel silly conducting it as well. So they avoid doing it. So if you're in that situation, which we are in Bristol at the moment, it might be that you start looking at this one. But again, that's a big change culturally if your unit has invested a decade of trying to do CAM-ICU. But you know, if it's not working now and it hasn't worked for 10 years, maybe it's time to change. But that's something for you to figure out in your culture. Obviously, kind of the most fundamental score we need to be aware of is RASS, and I'm sure you're all aware of RASS now. But I think the rule of thumb is if they're deeply sedated, there's no point doing it. It's not validated. So just have that in your thought process. If you get anything from me today, A to I, start playing around with that. And then the other one is PADIS. So start to try and formulate your delirium intervention around a framework. So the evidence tells us to use PADIS, which kind of is pain, agitation, delirium, immobility, and sleep. And it can be just a basic note within your notes. And what I tend to do with our team here is if we've screened them using CAM-ICU, this comes as part of the A to I. So under D, I will do a separate kind of section of PADIS as well, just thinking about kind of what we're delivering for that patient. So if you think about pain, kind of what score are you using? Is it an Abbey pain score? That's kind of the most used one with the nurses on the units. Is it chronic? Is it acute? Is it acute on chronic? What medications are needed and being delivered to support that? Are we providing too much medication? Is that causing polypharmacy? It's just something to think about, something for you to think about, kind of talking to your pharmacist on the unit as well. Agitation, what is the current RASS? What sedation agent are they is being currently used? Is there a weaning plan for that sedation agent? Is the patient kind of linked in to have a plan for spontaneous breathing trials for that day as well? So that's something you can influence on your morning ward round if you have an MDT ward round. Is there going to be a sedation break today? Are they going to do a spontaneous breathing trial? That's really important early days. Because all the evidence says if we can break the level of sedation, the outcomes are much better for your individual. If you think about kind of 20, 15 years ago when patients are coming to ICU, they'd be sedated with no kind of sedation breaks for 2 weeks, 2 months, and patients were coming out the other side in a right pickle. So we are learning from our mistakes. Delirium, have you scored them? What's our CAM ICU score? What is your delirium bundle delivery for the day? So that can be negotiated with your MDT at the bedside. Immobility, what was the current mobility strategy? Have you considered patient engagement? Kind of what is your next plan? Is that linked to your goals? Sleep is a big factor as well. So if you think about kind of the current delirium evidence, the only evidence to support us as therapists is mobilization and daylight. So within your goals, if you have somebody who's delirious, do not keep them in bed in a dark room. Get them up, get them engaged in activity, get them to a window, get them outside if you can, and try and involve your family members. That's a big win if you can. What I've noticed over the years as well is if somebody's tricky, these patients might be tied to a bed, so there might be a restraint. That might cause more agitation. They might be giving a cocktail of medication, so they might be given haloperidol, they might be given zopiclone, they might be given melatonin as well. So these are all factors that you just need to think about. Are we over medicating these patients? Clonidine is a big one as well. Over reliant on medication just to kind of support our care. And it is difficult if you think about a nurse at a bedside for 12 hours, trying to be, well, looking at the risk of kind of harm to them as well, and the patient. Sometimes you need to go to medication, but there are other things that we should be considering before. That should be the last resort. And a nice little slogan is no drugs. Well, here's try and think about plugs rather than drugs, but something that you can think about. Earplugs. If we look at kind of GPICs, just come out this year, so version 3, within the occupational therapy chapter, we've put it in as a standard. So we want all OTs to be aware of non-pharmacological treatment options for delirium, and we want you all to use a PADIS guideline to frame your intervention. It's evidence-based. It's all we've got at the moment. We need to start somewhere. And if we as therapists are using the framework, that will gradually build into the rest of the team. We also put it in the rehabilitation chapter as well. So it's not just about kind of us as OTs, it needs to be a wider delivery. And we've put that in as a standard as well. All intensive care staff with patients facing roles must have PADIS structure education as part of their ICU induction. There's a separate talk as well. I got an extra kind of quality standard in there as well, or recommendation about looking at holistic interventions and using activity. So we've got auditable sections as occupational therapists now within national GPICs that we can use and control. So think about kind of when you are doing your audits, there's standards and recommendations there that we could utilize to try and get more staffing, to link into normal ratios of staffing at least. Hopefully you're all aware of the guidance from ICS. So this came out 2 years ago, I think now. And we had a heavy influence as therapists looking at non-pharmacological approaches, but we also put in there some top tips about engagement. So if I just come off of this a minute and just open up, where is it? I just open up the I've lost my website. Here we go. Too many screens. So if we look at kind of the appendix 5, we've put in there some intervention examples as well. So we've broken it down into medical, physical sections. So kind of with the physical side of things, these are the things that we can start to promote as therapists. And we also put in a pinch me structure as well. If you didn't like the padded structure, you could start to use that if you wanted. And there is another one, I think. All right. There you go. So we've got the PADIS guideline in there as well. So it's a quick reference point if you wanted it. Try and get back to the presentation. So that's there as a resource for you guys. It should be kind of user-friendly, we hope. And what kind of Charlotte did last month was came up with a basic framework for you, just to start thinking a little bit outside the box and think about a different process. What I thought we'd do for the rest of the session is just kind of go around the room and just talk about your insights with delirium on your units. Where are kind of the blind spots, what you might need to kind of develop, and kind of maybe thinking about a process. I'll stop talking. Was that an okay overview of what you learned last time? Yep.
Yeah.
Okay, cool. I'm going to be mean and I'm going to point and ask questions to people. So I'm going to start with you, Sarah. Thinking about your delirium management in Swindon, is it MDT? Are you going in on your own? What are you doing? What framework are you using? Are you using a score?
MD, oh no, actually, like I would say nurses and doctors, probably more so than us as therapists. We are aware of it. We work with it in the respect of interventions. So thinking about the routine and what we're doing and our treatment plans. So I feel like we've probably got a reasonable hold on that side of it. I don't think I'm or as therapists, we do not look at like the risk assessment side of it. PADIS, I wanted to incorporate myself and learn about it since your guys doing the training a couple of weeks ago. So I'm basically at that starting point with that. I would say that the MDT we do work together in the respect of the doctors are very good at that, reducing sedation if they can. What can we work with? Let's get this patient outside, and then they look at us therapists, and then it goes into our treatment planning and more things like that. CAM ICU is an interesting one, and I think we're at a similar place to what you might be at in Bristol, because I don't think it's done. I think it's that end of bed thing. Looking at, I went back and had a little look at using this framework that your guys put on, and I went back and kind of used that as a bit of a starting point. And yeah, was looking at one of my patients' CAM ICUs, and yeah, I'm not convinced that they're done properly. So yes, I've got a lot of work ahead of me, I think, James, to get myself from an OT point of view really part of that structure and that team structure from an MDT point of view. I feel like I can bring so much more than I am bringing at the minute, but haven't had a clue where to start. So you guys doing this training and you doing this today has given me a better idea of where to start, how to start, but I might be in contact.
Yep, absolutely. And that's the whole point, isn't it? We just want to upskill, make sure that we've got a really strong voice as a profession.
Yeah.
And we're useful, because if we're useful, they want more of us.
Yeah.
Okay, that's great. I think that's a really good starting point. Thank you for being honest, Sarah. It's brilliant. Ben, I'm not going to be too mean on you because I know you in reach and it's not very often. Have you had any opportunity on ICU and Exeter or not since our last talk?
Not really. I've been off a little bit of annual leave, and equally we haven't had any patients be requested for us to see, so we haven't really been on ICU. So this is all kind of new, but it's very interesting to see.
Okay.
I'll probably come up in discussion with our teams here anyway.
Yeah, good. And it might be that you just, if you've got any free time, popping onto the unit and just exploring numbers of patients, just so you get a sense of the flow.
Yeah, it would be interesting to look at. Yeah.
I know it's difficult with, hospital flow and staffing. So appreciate that. Thank you for coming though, Ben. It's really good. Josie in North Devon, you're next on my list.
Yeah. So Amy and I are here. We're trying to dual this on her phone to speak to you, but we can see on the bigger screen. Technology. It's North Devon.
It's crazy when your phone's better than your NHS computer, isn't it?
It's ridiculous.
Yeah.
But we're winging it a bit. But we were both talking about this, and neither of us have been able to spend a lot of time in the last month on ICU since the training, and some of that is because we keep hovering between Opal 4 and critical incident over it, and so we're always diverted elsewhere. That keeps happening to us. But we were looking back over the patients. We feel like we've seen the patients we really needed to over the last month, which hasn't been a lot really, but we then went back over prior to that and had to think about if we'd had the knowledge that we got from this set of training, what would we have done differently with some of the patients that we remember as presenting with delirium and that we could have had more involvement with previously. So I would say that we've taken a lot away from that. We've noted that in the notes, in the patient notes, often when the CAM ICU is done, it just says positive or negative. It doesn't give a score. It doesn't give us any way of knowing how far along the scale a patient is. So we're going to put a bit of work into that and carrying out those assessments ourselves and getting more of a detailed result. We also noticed that very often the RAS isn't used when we're not there, and that's interesting too. So we often don't have a score to place as a marker to see whether we should be involved or not sometimes. So we're going to work on that as well.
It's a lot around documentation, isn't it? And what the nurses are using versus what's coming up in the training, and would be good just to have like a standardized between all of us, which would then help when the patients then move on to different wards.
Because we find that the nursing notes are very much copy and paste. They make slight tweaks to their notes from the previous shift, but they tend to pull through a lot of the same information over and over, and we need to get a bit more detail from them.
And quite subjective then as well.
Yeah.
Just positives and negatives.
Yeah. We also noted that pain, so there was a lot of talk about pain, wasn't there, and the impact that can have on somebody's delirium and cognitive state, and that's not scored. That's usually just they'll put a pain plus or pain plus plus, not a score that we can work with. So that's something else we've noted, that we're going to work on that we get more of an idea of what a patient is experiencing in terms of the level of pain, but also what is being done to control that. We noted there's several patients where they might be on oxycodone PCA, and then it said that forgets to use, or needs continual prompting to use, or blah, blah, blah. So their pain isn't being managed because they're not able to manage their pain because they can't press the PCA. So things like this are triggering thoughts in our head that, right, we have to be on this then because others aren't, you know. So we feel that we could actually have a bit of an impact with patients around those kinds of things. And
might be wise to link in with your pain nurse champion as well, because I'm sure there will be, and just highlight, is this good practice? Yes.
Yeah.
There's definitely a lot to work on, isn't there?
There is. We've come out with a lot to work on, James. We have. It's been a real eye opener for us, this session and the last session. It's been really interesting. Thank you.
Great, thank you. That's cool. And kind of, I think with these changes, then it needs to be a collaboration of your MDT. So kind of making friends with your nurses and your doctors, just to look at kind of change. Because if you're trying to do it on your own, you never make any headway. It needs to be a collaboration. Violet in Oxford.
Yes, I think we have seen a few patients. Actually, got one right now who is hyperactive delirium. So he's a patient that just came in with a type B aortic dissection. He's just traveled from India to visit family. 80-year-old gentleman, speaks Hindi. So we've got the language barrier as part of that. Very, very restless. He's been given lorazepam last night because it's pulled the NG, catheter, lines, everything. He had meetings when he came in yesterday. In the afternoon, he managed to settle because family was around. But this morning we came back to square one again. Yeah, but we managed to get him out of bed. He was communicating, wants to go to the toilet. We did do the risk assessment following the PADIs. Cindy's been quite useful and helpful in doing that, trying to be consistent. And I think the only thing that we probably need to do more, we discussed, is to do more of the ABCD, you know, now A to I bundle, which would be really good for us to look at those markers and everything. We do tend to look at it, but not in as much detail as you've explained this. I think that would be very useful in us explaining to the MDT what we're looking at, what our role is, and what that means. And we've already made plans about, he's normally quite active gentleman, about maybe taking him out, because in our ICU now, he was upstairs on level 2 where there's windows, but now we've got level 1 where there's no windows at all. And we have spoken to the division about it and how it's impacting the patients of delirium. But that's our solution for now. We have to compromise with the rest of the trust. So we have been trying as much as we can to get those patients out and get some sunlight and come back in. Yeah, that's where we are.
Good work. It's always a compromise, isn't it?
Yes. And so in terms of CAM ICU, I think we're also in the same place where the nurses will say positive. Rarely would they do it properly when you go and look and see if everything has been done. But like you said, end of bed, you know, what do you call it? End of bed. I like the word that you used.
Endobedogram.
Endobedogram. Yeah, definitely one of those is being used. But when we go around, we try our best to do it again, even though they've done it, just to make sure. But I think for those with the language barrier, it can be difficult. So maybe the other one may be a bit more useful to use. Maybe we'll have a look at that and see.
Yeah, absolutely. It's just making sure you've got the tool right for the job, isn't it?
Yeah.
Yeah. There's just changing tact a little bit, thinking about your language barrier. There was a talk the other day at a local conference talking about family recording messages on audio tapes or whatever, and you play that just to see if you can settle. That might be something to use with them. But it'd be interesting going back and looking at the biochemistry just to see, are we winning here, or do we need medical intervention to help us with the next phase?
Yes. Yeah.
So it'd be cool. Start, like you're saying, do your A to I and put your numbers in, start ringing the ones that are out of range and just see what your intervention does and what the outcome is. Great, well done. That looks great. Thank you. Okay, we'll go down to Bath. Manson?
Yeah, you can call me Winnie as well. Can you hear me?
You're very quiet.
Let me see. Is it better?
Not really.
Is it now better?
Little bit.
I'm trying to put it up. 20 seconds.
Say that again.
Is it better?
Oh, hello. Yep, that's fine.
Hello. Yeah, it's
Don't
Winnie
shout.
from Bath. Yeah.
Oh.
Yeah, I think we are on the right track, and our ICU here, we have been using PEDIS, we have been using CAM ICU like quite regular with patient. But I think the only thing we're not doing is we're not screening our patient, because I don't realize there is a standardized way you can screen the patient. I think it's quite a good idea to start with, but instead of like the doctor or the nurse telling us, oh, this patient is look like a bit delirium, and then ask us to do something. I think we can start our bit first, but before they telling us. And we have been also doing the ABCDE. Like, I think whenever we're seeing a patient, we'll do that. It's kind of a risk assessment. Yeah. But I just wondering, like, about the delirium management. This will obviously, like, it's quite standardized things you would do is setting up orientation boards, like, to get something familiar objects around the patient, set up the environment, exposed to the sunlight, trips out, doing some functional tasks like practicing in their own way, like shaving, like something different to those just washing and dressing their own clothes. It's other than that, it's feel like it's quite limited. It doesn't got any more creative stuff, you know? Because I feel like OT could be like more, but don't know what could be a good things to be like suggest. We try like coloring stuff with patient. Well, it's not relevant to delirium. It could be if something they enjoys, but other than that, it's quite limited like creative stuff to patient. This is what I feel.
Okay, Violet's put her hand up. Go for it, Violet.
Yeah, it was just to say on what you just say there regarding being limited. I think, I don't know, maybe personally it's just my take that I don't think we're limited as such, because it's the patients who kind of guide us what's meaningful to them. It might feel like it's not much to us, but it's so much more to them. Because I can give an example, the gentleman this morning. We got him up, set him up in bed. All he wanted was to get out of bed. It might sound like something very small, but that is everything to him. And he was giving us signs. We tried to give him something to eat or drink. He didn't want that. He just kept giving us signs of shaving. We got the shaver out. That's all he wanted to do. He wanted to sit out and shave. Maybe that's his daily routine before he eats, before he does something. So I think, yeah, as much as we may think that we are limited, but that is what we do as human beings. Like on an everyday myself, I'll get up. If I'm in hospital and if I shower, that is everything that I need, because that's my daily routine. I wake up and have a shower first before my day starts. Sorry, that was just my
I know, like even we do, like, I know this is kind of quite meaningful stuff to them, like to do it, but throughout the day, if the patient doesn't got any family member, well, I think it's not our business. Like they got quite limited entertainment. This recently we got quite a bit of patients staying here. It's more than 20 days in ICU. And obviously, like, the family won't be here all the time. They're being a bit fed up, a bit low moods. Like even we try trip out different kind of things, trying to get them entertained, and well, they're still engaging with us, but in general, like not brilliant.
Can I come in, Bristol? Do you want to go in first? Do you have a routine with the MDT, with the nesting staff to fill up
we
that
do.
day?
Yeah, we do.
And timetabling and scheduling with the patient
Well, it
involvement.
depends on do they want to engage with us? Like they do engage with therapists, but might not engage with their nursing staff.
And do they tell you the reasons, or they just don't want to?
They just don't want to, because
Yeah.
it's quite low mood. They just fed
Yeah.
up. Imagine
And-
you
and-
have been staying in like hospital, like just in ICU for like more than 20 days. It's quite tricky for them.
Yeah, and sometimes we just find they just respecting that, because they will eventually, with time, with consistency, be better. some patients just don't engage for a very long time, and then all of a sudden they just snap out of it. And it might feel like we're not doing anything. We might feel like we're being useless, but it's just individual personalities, isn't it? And the person that they are.
We did try like to get the family or the friends, the person their family to involve, like to get them encouraged. But most of the time, the family is a bit soft. It's not in a very good position to push them. The last time I got a patient, was engaging and then got delirium. We're still doing the delirium management with him, quite the standard bits, like offering daily, even he declined every day. He do got capacity. At the end, he not engaging for a couple of days and he passed away. So I just see anything could like push more, like get people engaging. I know it's their choice, but I don't know if any other activity would be more interesting to them. Even, we're trying to get them like doing some daily tasks. We know this is important to them, like because it's something essential occupation. But I was just thinking, can we start from other side, like something creative, more interesting to get their attention first, rather than like, just get them info first. Yeah.
I think it's a balancing act, isn't it? You've got to give respect to the illness and where they are with the trajectory of recovery. I totally kind of echo everything Violet said. I don't think we should kind of downplay activity, basic ADLs, especially looking at kind of structure and going back to circadian rhythm. That's kind of gold dust if you can kind of support that, especially in these early stages of kind of recovery. There was a really good kind of webinar via the ICS back along, and Southampton did a talk about the use of volunteers. So they've had a really positive outcome with their volunteers team. So the therapists will kind of see them, screen them, set up appropriate activities, and then volunteers will come in 3 times a week to deliver the activity. So that might be something that you could think about.
Yeah, that sounds a good idea. Like if they kind of got someone kind of outreach like to the patient.
Yeah,
it's quite interesting things.
I've got a presentation from them, which is really fascinating, so I can share it on this group if you'd like. So we're looking at that here at the moment. Good. But yeah, keep on going, Winnie. Like if you come up with some strategy, share it within the group, because we're all frustrated with it, mate. Sometimes we're just limited about what we can deliver in an acute environment. It is what it is sometimes. Okay, thank you. Christina in Gloucester.
Hi, yeah, I'm sorry. I think we're very behind the times here in Gloucestershire. OTs haven't really made it onto our ITU wards. It's just very much in the beginning process, which is why I wanted to sort of join this group, just to see what's happening out there and see what we can implement. So yeah, I don't have much to add, I'm afraid. I've been a few times on there, but it's normally just helping the physios with some mobility practices and things. We've done a few functional dressings, but it's been very limited so far.
What's the next plan?
There isn't a definite next plan. It's just about thinking what we can do.
Yeah.
Yeah, it's all very, very early stages, I'm afraid.
Is there scope for a criterion that you could kind of go in and start building a case?
Possibly. I think, people are open to it. As I say, it's just very, very early stages at the moment. I think when we have been on the ward, they've always sort of welcomed me with open arms and are very keen that we could be involved. It's just working out where to start, really. So yeah. It's in discussions at the moment. Tricky. But very early stages, I'm afraid.
That's great. At least, it's a problem and you're starting to talk about it. And you're wanted. That's kind of the big step, isn't it?
Yeah.
If you need any help, please let us know.
Okay, lovely. Yeah, thank you.
I was going to say, Christina, if you need to come along to any of us, I mean, I don't know, with Swindon, we might be one of your closest. I don't know where you are. But yeah, by all means shout, and even just come along and help. What size is your unit?
Well, I'm based in Cheltenham Hospital, which is much more the smaller unit, but it is considered sort of the rehab unit. Gloucester's the bigger hospital with a lot more. I mean, at the moment we've only got 2 patients in Cheltenham, but I know my managers have been very open to me sort of reaching out to other hospitals just to see what's going on there, because I think at the moment it's such a new area to me that I don't even know what I could be doing. It's just completely new, completely different.
Yeah, and where to start and how to build with this.
Yeah,
so
exactly.
I was definitely in the same position as you 5 years ago. So by all means, like James said, shout to people around. We're in a 12-bedded general unit here in Swindon, so sometimes it's I've been down to Musgrove to where Sophie works, because they do a similar unit to us, general 12 beds, or they're a bit more than us. But it was really helpful to kind of connect in with the people that are doing similar, and how you build that into the hospital. So yeah, definitely shout if you need to.
Okay, thank you. That's great. So thank you.
Great. We're bang on time at 11, which is good. Is there any kind of other discussion points or any questions that anybody wants to ask? Anybody in the room? There's a really good point Sarah's made, like having comparable peers in comparable units is really useful. Just because kind of services are very different. Everybody happy?
Yeah, thank you, James. That's brilliant.
No worries, no worries. I think the next one is upper limb, isn't it? It's my favourite. So I look forward to that. Very exciting. No worry, Josie. See you later, everybody. Have a lovely week. Bye. Thanks, Sarah.
Thanks.
So will you kind of record that and pop that onto the website then, or?
Oh yeah, if you want it to go on the website, it can go on.
I think it's useful. I think it's really nice to add the next stage, because I think with the first one, we're kind of giving new concepts most of the time. So they've had a month to think about it and play around with it. And then we add a little bit more in, which is quite nice.
Yeah, lovely. We'll add it in.
Did it come across okay?
Oh, brilliant. Yeah, really good.
Good.
I mean, I'm not medical, but I found it really interesting. So
No, it must be lovely just to kind of listen and just say, oh, wow, this is what they do.
yeah, it's really good. And I feel like quite interested in delirium and things anyway. It's something that we've done quite a lot on as a network, and it's just, I mean, it must be awful to be in that state. So I think it's lovely that you focus on it and try and help.
Yeah, it's fascinating, but like I said at the start, it's fascinating but really frustrating, because the evidence isn't moving forward. And I think it is just part of being human and being ill.
Yeah. It's a shame, isn't it? It just doesn't seem to be something we can avoid, but
there's got to be some consequence, isn't there?
Yeah. But no, it was great. Really good, James. Well done.
Lovely. Thanks, Sarah. Nice to see you again.
And you. Bye.
Bye now.